We are just at the start. So the first proteomic studies also in CSF, they had a bit of disappointing results. And I think that's because the classical approach is to take cognitively normal people and Alzheimer's disease dementia as two groups. But some people with normal cognition can have abnormal amyloid, and some people with dementia, they can have a different pathology than amyloid or tau that's causing the symptoms. So this is all noise that makes it more difficult to find differences between groups. And what we are doing now is to refine the diagnostic labels within patients that have amyloid abnormality. And what we now see is that there's huge amounts of proteins that show very big differences between particular subtypes and controls that are lost if you take everyone as if they belong to the same group. So as I said, this is just really the start. And I think as we learn more about all the different biological factors that influence how Alzheimer's disease manifests, and then we have more clues to develop personalized treatments. So that's the other really strong point of cerebrospinal fluid proteomics. It will also provide us at the same time with a tool to also select the individuals that best match the treatment. And maybe in the future, we can do the selection with blood as well. We can now detect 4,000 proteins in a cerebrospinal fluid using an untargeted mass spec approach. And so these protein levels, they reflect which particular biological processes are changed when you compare them to a control group. But this information is also something that we can measure in brain tissue. We can measure this information in mouse models. We can measure proteomics also in cell cultures, iPSC models. So it's really a tool that can bridge the patient to the clinical models and back again.